you. If there are no further questions, we'll move to Tom Power's presentation. Tom is the Chief Information Officer for one of the great assets in Cincinnati, which is HealthBridge. Tom has actually been in computing for 35 years. That probably means he invented the computer, if not the internet. But that said, he apparently has a very dry sense of humor, and he would like to take credit for the weather today as well. Tom, please.
All right, thank you. Oh, great. Yeah, I'm the computer guy, right? Yeah. No, I've got a stethoscope here somewhere. I'm here to talk about some of the technical initiatives, both within the Beacon program and outside of it, that we're using to support transitions in care. Just a little background on my employer, HealthBridge. I've only been in town probably 5 months, and you have to ask yourself, what was it about HealthBridge that drew me into the area? And it's particularly compelling when I tell you that I'm a die-hard Pittsburgh Steelers fan.
No.
Now think about the implications of a Steelers fan leaving the comfort zone and moving to Cincinnati. There has to be a compelling story with HealthBridge, and it is. It's been around for quite a while. I think the statistics are quite compelling. We're moving over 3 million results. Many of the things that I'll talk about in a minute could not be done if you were not moving the kind of data we're already moving from the providers throughout the area. So understand that HealthBridge is a significant enabler around some of the care transitions and other activities that we'll be discussing. What am I doing here? Okay, just to give you a little framework, I'll only be up here for a short time. That's because computers work much faster than people in care transformation processes. We'll go over a couple of definitions that I think you'll be exposed to around care transition and electronic medical records. I'll talk to you about something that if you have not heard about it yet, you will hear about it in the future. People refer to it as C32. It's a secret government project. No federal funds are available to the uninitiated, so don't ask. And there is no C33, not at this time, or at least that I can talk to you about. We're going to talk about 3 specific initiatives: an alert system for ER admissions and inpatient admissions that will be part of our Beacon work, but has already generated a lot of enthusiasm outside of the Beacon program. We're going to talk about a new program where we can rapidly identify readmissions for all of our area providers where readmission is occurring within 30 days. And we all know that there are significant incentives or penalties, depending on how you look at it, around that situation. And then exactly what the summary record exchange process is. I don't know, I'm actually a marksman, but this gun is not working for me. The first thing I want to do is talk to you about a concept that has been referenced in the meaningful use criteria, that of a continuity of care record, and how it may be different than a continuity of care document. And the answer to that, again, is secret, classified, but I'll try to share it with you. I think they want the patient to walk away with some kind of record or be able to receive a record of the care they received in the office after each visit. And they've given it the name of a continuity of care record, and it has some minimal criteria around it where they want to know medications, problems and allergies, and maybe some lab test results. Things that you're prepared to share. You can share it in paper form, and in fact it has to be available in paper form, but you can also put it on a thumb drive, or you could put it on a CD so that they would have it if in fact they desire to walk away with it after the end of the visit. So that's kind of a patient-centric thing. It is a computer-based document, and if I showed you one, those of you with advanced skills in the practice of medicine could make no sense about it at all, because it is in a language called XML. But the good news is they have to be able to translate that into something that's readable, and normally that accompanies the document at the time you receive it. Now, I don't want anyone to read the next slide, so please hide your eyes. We've talked about continuity of care record. Now we're going to talk about its brother, the continuity of care document. Now I see people reading it. Don't you see the warning on the bottom? It says if you read this, you won't be able to operate heavy machinery this afternoon, and you may not be able and safe to drive. So, but this is from the American Medical Association. It tries to describe the aegis of what they call a continuity of care document. It's a more technical definition that you find in IT publications, but it has some interesting components that I've highlighted in red. First of all, it is technical. It's based on XML, and everybody in this room really doesn't care. So I just thought I'd share that with you. But the second thing is, it was developed from the original concepts that created the continuity of care record, the CCR. So they are closely related, and for most people's purposes, they can be used interchangeably. And then finally, you have to be able to print it out in English. It's designed principally to talk from an EHR to another EHR and transfer data in so that it doesn't have to be re-entered manually. But it is possible to print out its contents in English so it can be interpreted by a human being. Go figure, I don't know why they need that capability. Now, what is a C32? Now, the reason I say this is a number of vendors will talk to you about these summary records that they're able to exchange between EMR vendors, and they will often refer to it as the C32. It is probably the most robust computer-generated record in terms of the amount of clinical information it contains. So that's why if you want a summary that has a fairly broad application, a way to transfer information from a hospital to a primary care provider after an inpatient visit or an ED visit, it's a logical choice. There are many other kinds of records that are skinnied down that carry specific information for that exchange. But the C32 is often referenced, and it is a continuity of care document when one EMR is going to talk to another EMR. Yes, sir?
How detailed is that? For instance, does it do discrete lab values?
The implementation varies. They do want it to do discrete lab, discrete allergies, discrete medications, and discrete problem lists. And I'll talk to you about some of the challenges around that. But not all C32s are created equal. There's enough flexibility there to make it difficult to use. But by making it flexible, there are a lot of people that didn't get upset with you when you said you need to be able to do this in order to get certified as an electronic medical record. Now, even Epic, I know you're not familiar with Epic. It's a electronic medical record vendor from Wisconsin. Even Epic, primarily for Care Everywhere and Care Elsewhere, its foundation, it uses the C32 format. So it does have a significant relevance to this community. I talked about the minimum content, but there is a whole lot of deep content, from financial information to social information to prior medical history, along with medications, along with the test results. It's all contained in this record. The kinds of records that we send around nowadays probably have 500 to 1,000 characters on average. This record, this CCD, is a monster, a monster. So the mechanisms we'll be using to transfer it will differ from what we use today for the 3 million results we deliver each month. And the intent, again, is to inform the receiving provider of information that's essential to taking care of the patient. It could be a consultant that has been asked by a particular provider to see a patient. It could be the hospital advising the primary care provider of the status of an outcome of a recent admission. But it's to inform the provider on what's happened with the patient, and that's why it's important for transitions in care. When I first saw C32, I decided that it was a new form of an acronym. We use a lot of acronyms, so I call it an acronym because it really doesn't mean anything. It's even more confusing than all the acronyms we tend to use in healthcare. So I searched Wikipedia. They have yet to have anybody define what that is, so I may be onto something. The first specific technology implementation that we're using to support care transition is in some ways a preemptory strike. If you have a patient, and during the Beacon program, we're monitoring patients who have asthma as well as those that have diabetes. If that patient hits the door at an emergency room, that primary care provider will know it, and will know it within minutes, depending on the way they would like to be informed. Now, you might say, well, that's like your neighbor calling you and telling you the horse just ran out of the corral. Sorry about that, but at least you're aware. And in some respects, that's true. But when that patient shows up at the emergency room, we're looking to put in place an aggressive root cause analysis to follow that patient very close to the time when the event occurred to try to identify why this particular event happened. Now, most of the time, we would like to think that it's not related to their chronic condition. And in that respect, when it's not related, it's just more informational. But if it does show up as a complication of their underlying chronic illness, it will involve rapid root cause analysis, very close to the time of the event, while the circumstances around it are fresh in everybody's mind. And on top of that, it is predictive of what? Another pending transition in care, because the hospital will be treating that patient and returning them to the practice. They may have a changed medication, they may have a new problem diagnosis, but you're aware that a transition will be happening, within hours or days. we do this by monitoring all the ADT messages that come out of all our local acute care providers. It does trigger a variety, especially in the QI efforts that are going on within the Beacon region. But we've had interest from a home health agency. They felt this would be great information to have if one of their clients shows up at emergency room. They felt as though it would be possible to potentially contact the emergency room and intervene and provide some home care after the visit was over and maybe avoid a 23-hour outpatient observation stay. So, and then there's a Council on Aging, which has a less clinical focus, but is determined to try to keep the patient at home. And there are a variety of interventions. When they find out a client potentially has been hospitalized, they really want to work towards getting the patient back home, which is clearly the less expensive mode of care. Why do I do this? There. Now, one of the other exercises we're going through in cooperation with the Greater Cincinnati Health Council is zeroing in rapidly on potential readmissions within 30 days. We have the regional view. We know if a patient and when a patient was discharged. We'll be able to tell those providers what hospital they ended up showing up at. It may be one of those qualifying readmissions that Medicare talks about. They say as many as 18% of their patients are readmitted within 30 days. That's a very humbling statistic. Now, the good news about that is that when they've investigated that, it's really not because of substandard care in the hospital that they were discharged from. It's because of a variety of other reasons, of which hospital care received may be just one and maybe not the major reason for the readmission. However, knowing it, being able to react to it, there are serious financial implications going forward in 2012 when a readmission occurs, and it penalizes both providers. So we're anxious to deploy that in cooperation with the Health Council. And the last but not least, the most traditional kind of transition in care where a summary record is expected to be exchanged between EMRs is patients discharged from a hospital. He shows up in the primary care physician's office. They have no idea that he was even in the hospital and no idea what happened while they were in the hospital, what medications may have been changed, what the discharge plan may have been. It's the primary opportunity to really make a difference in managing that patient's care after they've had an acute episode. It's very interesting. Before the Beacon work even started, there was a group supported by the Greater Cincinnati Health Council that was investigating the information that they would like to see when a patient is discharged from a hospital and before the patient hits their office again for their next office visit. So they'd gone through the collaboration around developing that data set, and we're going to be using that information, which took months, if you can imagine. We're going to use that information and assist with sending around those types of structured, focused discharge summaries, after they've been either in the emergency room or had an inpatient stay. So to sum up my few words of wisdom, for those of you who either have an EMR or who are planning to install an EMR, And the first is, you've probably seen a lot of bumper stickers on people's cars say, "Just say no." Those were incomplete. They should have said, "Just say no free text." Do not put free text into your EMR if you can help it. Particularly, don't put it into the medication section of the EMR. And if you don't do that, everyone will like you. And you will be able to receive and provide information that's very, very accurate and complete to providers that are also taking care of your patients. Free text is not free. The penalty is serious, and it relates to the third item, and that is using standard coding systems wherever possible so that your understanding of the patient's conditions is the same as the receiving provider. It is very important wherever standards are available to use those standards. RX norm is a common standard among medication and pharmacy ordering. LOINC has a broad application, but it's targeting specifically laboratory results. SNOMED codes medical conditions, among other things, and obviously you're already familiar with ICD-9 because it impacts how well you get paid. When you're working with EMR vendors, recognize that if they're a certified EMR vendor for meaningful use, they have to be able to exchange a summary record. That means a lot of things to a lot of people. Don't just assume it's the right thing and that you'll get all the information and it'll be able to populate your electronic medical record. That is not yet the case. So be cautious, accept what you get. It may be as simple as looking like a summary record in a transcribed report format, where you'll have the information, but it won't be populating specific areas of your own electronic medical record. And I guess finally, don't fall for what I call the Goldilocks syndrome. We all remember Goldilocks. Well, Goldilocks went to medical school. And she was practicing at the Great Wolf Medical Center out in Wyoming. And when Great Wolf discharged one of her patients, she would look at the discharge summary and say, "Why don't they give me the information I need when they send a patient back to me? There's not enough information here for me to properly assimilate and continue treatment for this patient." So Great Wolf turned around, installed Epic, and sent her a 27-page discharge summary after the next visit, and she said, "This is way too much information. I can't find what I'm looking for. Why do you do this?" You know, it's like it's either too much or too little. Well, these summary of care records hopefully will have more than you need, but more than you ever had, and hopefully as a starting point to get to the perfect package of discharge information, it'll be a good waypoint along that journey. So don't bite the hand that feeds you. When you do get that extra information, just smile and say, "Wow, never got this before." Okay, well, that's all I have. If you have any questions, I'd be happy to take them.
To the right, please. Go ahead.
Yes, sir.
Will the mysterious C32 be the messaging format to exchange information between EMRs when they eventually decide to do it?
Yes. My suspicion is yes. The transport, the way it'll be sent, may be a little different than you might get information today, but the C32 seems to be right now the gold standard. That's what everybody talks about. There's so much flexibility within it. It's like having a file cabinet with all these folders in it that are empty, and they'll stuff information into various folders. Some will put more in one folder than another, but it's a fairly flexible data model. Yes, sir.
Have you heard about Project Direct?
Yes. The Direct project is again, it's a federal project. Direct in particular is to distill it down, it's basically secure email. They will get this summary record. They will properly identify either end, both the sender and the recipient. They will encrypt the contents of that record, and they will send it from one provider to another. And they can send it even if there's not an HIE on either end. So it has that flexibility. But it's for kind of point-to-point communication between providers. Connect is a more sophisticated model where there's kind of a data warehouse somewhere, and the permissions to use Direct are really granted by the physician or provider that's sending the information. And they usually have the authority, or if it's related to patient care, to send that information out. With Connect, it gets much more squirrely around privacy concerns and patient permissions, because with Connect, they can query and say, do you have any information on Tom Powers? I mean, any information from a hospital, any information from a physician office, and show me what kind of documents you have on Tom Powers, and then I'll pick the documents that I want and I'll pull them back to me. The privacy implications of that are fairly onerous. And I think because of it, there'll probably be a lot of difficulty implementing it. Direct is probably cleaner. As my chief privacy officer sitting in the back will attest. Okay, thank you.
For the sake of staying on time, go ahead, Tom. The slides that I had are in your package, so I'll just go briefly over a couple of issues that we did. Who we are is the Accountable Care Transformation Leadership Team, and we are a group of CMOs, CNOs, Chief Quality Officers from Greater Cincinnati that meet on a regular basis. And we started as a health quality improvement project for Cincinnati. And we used the basic triad of quality, which is create a structure, use a process, and find an outcome. And we moved three major things, which were which were basically your core measures in three areas: acute MI, heart failure, and pneumonia. And we moved those very significantly from the 60% to the 90% range. So what we were able to prove is that we as a system, as a healthcare system, which is the Cincinnati healthcare system, Greater Cincinnati, can work together across different systems such as Christ Hospital, the Alliance at the time, University Hospital, Mercy's, TriHealth. We can all work together towards the goal and we can accomplish it. And this is my caution, is be careful not to be a failure because of the success measures you have. What we tried to prove is that we can move those measures thinking that those measures are actually an end to itself, and they are not. And the reason I'm saying this, and I know this is blasphemy to a lot of people, but if you look at our heart failure measures, if we are able to reach 92% of our core measures and accomplish those on every single patient, why do we have 23% readmissions? And that is why the transition of care is so important, because what we found out now, as we take on our new task, which is reduce readmissions by a specific number by the end of the year, is that it is not only about the clinical part, there's also the human factor, which we sometimes miss. So the patients that are coming back, they're coming back because they did not take the diuretic we gave them. And the reason they didn't take the diuretic we gave them is there's only one bathroom in a household of 6, and they're not gonna do that. They're not gonna have accidents all the time. Or they cannot afford the medication. We gave them instructions that they couldn't understand. We gave them labels on their medications that they couldn't read. So all of these things are really important. When they got to their primary care physician, they did not have any of the records from the hospital. When they went back to the ED had no idea that they were in another hospital, and on and on and on. So that is why the transitions of care are so important to what we are doing. And that's why measuring success is really important, but knowing what to measure that's really meaningful at the end is really important. So I'll leave us with that challenge and be able, any questions for any of the panel, please. Okay. Enjoy your lunch, and please don't forget to fill your evaluation, and I appreciate it. Dora, any words of wisdom? Thank you.